All right, here we go with part 2 of the cardiovascular system. What we had just gone through in part 1 was anatomy, function, and a brief overview of the systemic circulation. This section is going to go over cardiac disease and dysfunction, and the third section will go over vascular disease and shock. So let's talk about coronary artery disease. The picture that you see there, you've got your healthy artery all the way on the left, and then you can see it progresses all the way up to almost near complete occlusion on the right. So what happens when we've got these buildups of plaques within our arteries causing the coronary artery disease is we end up with myocardial ischemia. We don't have enough oxygenated blood getting to our cardiac tissues that are demanding it. So what happens when that happens? Well, if you can remember way back in the day when we talked about glycolysis and creating ATP, our energy, when we don't have oxygen, we're in this green zone here. When we do have oxygen, we're able to go through the Krebs cycle and produce a whole bunch of ATP, and everything's a nice clean process, and everybody's happy. When we don't have oxygen, we go through an anaerobic process over here, anaerobic being without oxygen, and then we end up with a really nasty, messy process producing ethanol and lactic acid, which builds up in our tissues, and that's bad. And on top of that, we only get too little ATP. Where'd my arrow go? There it is. Too little ATP. So not only do we have all this horrible byproduct coming out, we're only getting, microscopic amount of energy compared to what goes on in an aerobic process. If this goes on long enough, where we have persistent ischemia, or we end up with complete occlusion, which causes acute coronary syndromes, we end up having either a diagnosis of stable angina, unstable angina. We have different types of myocardial infarctions. We have STEMIs, that's a ST elevation MI, or we have an NSTEMI, which is a non-ST elevation MI. So we're going to talk about these syndromes in a little bit more detail. The major risk factors for coronary artery disease and acute coronary syndromes are this whole laundry list here, and this is just the major risk factors. There's actually a lot more. Smoking being one of the most prevalent ones you'll see in your patient population. Take note, though, of this list, the vast majority of the things on this list are modifiable. So this is a disease that very easily can be not completely reversed, but it can be slowed down, it can be backed up a little bit, and it can definitely be avoided, right? Let's talk about dyslipidemia. So we have lipoproteins, which are either lipids, phospholipids, cholesterol, triglycerides, which end up being bound to carrier proteins. That's how they move throughout. These actually are good things when they're in numbers that they're supposed to be. We need these for normal physiologic functions. It only becomes pathological when we have too much of it, or in some cases, too little. So you take these guys, these lipoproteins, they go through the liver and they get processed into these units. And then we label them as either very low density lipoproteins, low density lipoproteins, or high density lipoproteins. The LDLs are bad. Again, in high number. We do need them for some things. But when they're in excess, this is what leads to the atherosclerosis, that picture that I showed of the buildup, the deposits, the fatty deposits. And the way that we treat people that have high LDLs is with modification of their diet. And then also sometimes we'll put them on statins. So this is your simvastatin, lovastatin, pravastatin, statin, all your different statins, right? And then we have HDLs, and we actually like these guys. These are the ones that move cholesterol back to the liver. This is the one that's going to get the cholesterol out of this the bloodstream. But when they're low, then it's a problem because they're not moving the cholesterol back. The one other thing that HDLs do is it repairs the endothelial lining. So when we have these plaques within our arteries and they break off, your body responds as if anything broke off. You have this damage going on along the endothelial lining of the vasculature, and so your body's going to want to go in and repair it. This is what the HDLs do. They go in and they repair things like that. So it will decrease risk of developing clots. So we want these guys around. So when they're in too low of a number, it becomes a problem. And then your very low density lipoproteins, similar to your LDLs, but these are your triglycerides. And when they're in excess, they can increase your cardiac risk as well, especially in combination with the LDLs. So let's talk about myocardial ischemia. An ischemic attack, okay, and ischemia, as we know, that's a lack of oxygen. We're not getting the oxygen that we need for cellular metabolism. So it can be transient, which means it comes and goes, or it can actually be, full-on myocardial infarction that causes cell death. And so I got the 20 up there because that's really the number, on average anyhow, that is going to make or break whether or not you have permanent damage to the heart tissue or not. So at about 8 to 10 seconds after oxygen deprivation, your cells will go from aerobic metabolism to anaerobic metabolism. So they start going into the anaerobic metabolism and they start to die relatively quickly, but the tissue can be regenerated, restored, if you can return the oxygenation to the tissue in under 20 minutes. So let's talk about the rupture of the plaque that leads to obstruction, okay? This is what I was talking about, the HDLs, going in and removing some of this stuff. But you have those plaques that you see in the artery there, and it can cause the coagulation and the development of thrombi, and then you end up with a complete occlusion of your artery. The other thing that can happen that causes ischemia, with or without any type of plaque development, is a coronary spasm. So when the arteries clamp down, having a spasm, we'll talk about Prinzmetal's angina, it can block the flow of the oxygenated blood. So that's going to deprive the tissue on the other side of it of oxygen. Then we can even have hypotension, where we just don't have enough oxygenated blood being delivered to the tissue. We have dysrhythmias that disrupt the cardiac output of the heart, so we don't have, again, oxygenated blood, enough of it getting to the tissue. And then we can also have anemia or hypoxia. If we have anemia, our blood's just in and of itself deprived of oxygen. And if we are in a state where we're hypoxic, we're not breathing well, we're not getting oxygen. So it's not always necessarily that you're ending up with a infarction or a blockage in your artery. There are other things that can cause ischemia in the tissue. So we have transient or reversible hypoxic events. These are stable angina, Prinzmetal's angina, silent ischemia. We'll talk about these individually. So stable angina, you've got that artery there that's pretty well built up, full of fatty deposits. And what happens when you have a situation like this and you have the buildup of these plaques, the patient is going to be moving around, doing stuff, even something as simple as walking up a couple stairs. It's going to exert this level of stress on the heart. The heart rate's going to increase, all of these things that happen when we exercise, and it's going to increase the oxygen demand of the myocardial cells. However, because you have this near occlusion, it's unable to deliver the amount of oxygenated blood that it needs. So what you end up with, a patient complaining of chest pain or heaviness in their chest. It radiates to their arm, their jaw, their neck. They become pale, diaphoretic, short of breath. And this is what you'll see. But they're considered stable because if they rest, if they sit down and they chill out, we have nitrates that we can, sublingual nitroglycerin tablets that you'll see patients will have to relieve the pain. However, these patients are at high risk of getting a myocardial infarction. So we have to watch these patients carefully. These are the ones where you tell them, if they take a couple nitrates over the period of 5 to 10 minutes and their chest pain's not going away, they have to call 911. They're at high risk of having a heart attack. All right, so Prinzmetal's angina. This is the spasming I was telling you about. It clamps down, as you can see in the picture, and it allows less blood to get through. So this can happen with or without the atherosclerosis, as I had said. There's multiple causes for it, whether it's decreased vagal activity or tone, malfunction of the sympathetic nervous system, issues with calcium channel function, inflammatory mediators, things like that, autoimmune issues. There's a lot of different things that can happen with it, but it's usually benign. It can cause dysrhythmias, though, so it is something that needs to be taken seriously. Silent ischemia. This is something that patients will often not even have complaints about. Or if they do, they're vague, like fatigue or dyspnea, or they just don't feel right. They feel uneasy. They might even complain about, having the flu. The things that can cause this are diabetes, stress, complications of CABG, coronary artery bypass graft, or transplantation. So you can have some post-surgical ischemic changes. And, we've all heard of people dying from a broken heart. It is true. The stress of those situations can actually cause ischemia of the heart, and in some cases can lead to dysrhythmias and even death. So how do we diagnose and treat this? Well, if we've got a patient that has an elevated troponin, and they have an elevated CKMB, that's creatinine kinase myoglobin, I believe, which we don't really do CKMBs, we do troponins. And you'll just see it as troponin. I know that we've got two different types here, but we call them troponins. And anything above a 0.04, we get suspicious of, and it's something that will trend. And the higher it is, the worse it is. When we do use CKMB, the normal, it would be anything higher than 5%. We also use EKG to diagnose. If we see ST elevation, that's what it looks like, you've got the normal on the left and the ST elevation on the right. This is when you've got ischemia going through all the layers of the heart tissue. Then you'll have the ST elevation. It goes all the way through. When you have T-wave inversion, which you'll see, like this EKG shows, it's just affecting the lower level of the myocardium, just above the endocardium. It's not going all the way through. There are CTs, angio-CTs that people will do out there, and stress tests that they quite often do. Sometimes they're on a treadmill, sometimes they're chemical stress tests. And, we don't really put somebody on a treadmill and do a stress test if we think they're having a heart attack. So this isn't diagnosis of an MI, this is more diagnosis of coronary artery disease. But if there is any type of suspicion, in cases of stable angina and such, they'll do stress test. But ultimately, what we're going to do is we're going to send the patient to the cath lab. This is percutaneous coronary intervention. And they go in with the balloon that's got something that looks a little bit like a chain link fence. They go in there and blow up the balloon and insert the coil, the stent, like you see in the picture. Coronary artery bypass graft is kind of the end of the road when things are really bad. Stents aren't working. You can't get it through because they don't always, when they go in and they do in the cath lab, they can't even break through the clot in order to put that balloon in there and the stent in there. So they'll do this, and you can have a single, a double, a triple, a quadruple. If you have to bypass, which is why it's called bypass, multiple different arteries in order to make sure that every area of the heart is getting oxygenated, then you end up with a quadruple bypass. However, if there is just one area that needs to be bypassed, then you'll end up with a single, and then you've got the double and triple for situations that are in between. Acute coronary syndrome. So this is when coronary artery disease hits the end of the road and it gets really bad, and you have an acute situation where, as shown in the picture, you've got a clot that's stuck right there on that plaque, and you've got complete and total occlusion. This is unstable angina or angina, depending on how you want to say it, and NSTEMI in situations where They have acute pain at rest, so this is no longer stable. They can't like just sit down and feel better. Their ST is either normal or actually a little bit depressed, and they have the T-wave inversion because they've got the ischemia partially through the tissue, but not through all layers. And you may see a slightly elevated troponin, but it really is only affecting the lower layer of the tissue. We're going to treat those with oxygen for sure. We want to oxygenate the tissues. If a little bit of blood is still getting through, we want to make sure that it's carrying a lot of oxygen to help out. We'll give nitrates to dilate the arteries, and beta blockers to decrease the work on the heart, heparin to try not to create any bigger clots going through there so the clots don't build up. We have ACE inhibitors as well. And then again, the PCI, the percutaneous intervention, for situations where we really need to get through to reperfuse that area of the heart. The thing with this is you need to take in a lot of consideration where the blockage is. So the higher up on the artery, obviously the more critical, and the lower down, the less critical. And that's where troponins and EKGs really kind of help to identify how bad it actually is. So when it is bad, this is our EKG. So we've got a STEMI, ST elevation MI. Well, you'll see it in multiple different leads. It needs to be seen in more than one lead. We're not going to go into a 12-lead EKG reading or anything like that right now, but just to let you know, it's not, if you see a ST elevation in one lead, that's really not significant. It's got to be in more than one for multiple reasons. But anyhow, so here you'll have your STEMI, and this is your transmural, and transmural means that it transcends all of those different layers of cardiac tissue. Like I stated earlier, the ischemia starts in 8 to 10 seconds after the infarction, and cardiac cells can recover if the oxygen is restored in under 20 minutes. Otherwise, necrosis occurs. So here's a really cool depiction where you have a normal EKG, which actually really does, normal EKG doesn't really look like that, but that's okay. And then ischemia, you've got the, if you look at in the zones over here, where you've got ischemia, you're just showing you the inverted T wave. And then when we get to injury, so you've got hypoxic injury, so we're leading to necrosis, you have that ST elevation. And then once the tissue's dead and gone and irrecoverable, you end up with a wave that looks like that. So the troponins and the CKMB are released into the blood because they come out of the cells. Once the cells die and they break down, that's when the troponin's released, and that's how it ends up into the blood. And the more cells that die, the more troponin there is, and that's where that correlation comes in as far as how large the damage is directly related to how high the troponin is. And like I had said, the severity depends on the size and the location of the infarction. The higher up on the artery that it is, the more the heart that it's going to affect, like a tree, right? You got a big clot in the trunk of the tree, the whole tree is going to die. But if it's out on some peripheral branch, it from the trunk all the way down to the last little leaf, you've got this whole spectrum of disorders that you can end up with depending on if the tissue dies. So these things cause cardiac dysfunction, dysrhythmias, and even death. The troponins are significantly elevated and continue to climb if it's not treated. Obviously, more and more of the cells are going to die, releasing more and more troponin. So we do trend troponins in the clinical setting over time to make sure things are getting better and not worse. And then we treat with aspirin, nitrates, morphine, and ultimately, again, with PCI. There are situations when you can't get somebody to a cath lab, and we actually give them TPA, which is, the clot-busting drug that we give to people having an ischemic stroke, because it'll break down a clot in your heart, just like it does in your brain. But for the most part, we've got enough cath labs all over the place that we can get somebody to in enough time that TPA is not necessary. Let's talk about the heart wall disease and dysfunction. Pericarditis. So you've got your pericardium that we had shown earlier, and it's got different layers there that you can see, filled with the fluid protecting the heart. But it can get inflamed. It can cause issues, as we'll see here, with acute pericarditis. Inflammation of the membranes, like I had said. It can be caused by a number of things. A lot of times it's infection, viral or bacterial. But when you have a MI, myocardial infarction, and tissue cells die, and you have all of those inflammatory processes that go on with cellular death, that can cause the pericarditis. And then we have radiation therapy, and there actually are a number of other things that can cause it. A lot of times it's idiopathic too. Effusions, which is the fluid that builds up, can lead to constriction and cardiac tamponade. So that fluid, when we had talked about earlier, I don't know if that was in part 1, there's about 200 milliliters of fluid that's in your pericardial sac, and just a small increase of even 50 mLs can really cause some serious constriction on your heart. And when you get up over 100, that can actually lead to death, where you have cardiac tamponade, where your heart is just squeezed so small that it can't even beat. It's similar to brain bleed, right? You get a significant brain bleed, and your skull can't, only allows so much room to play. So clinically with these patients, what you're going to find is they're going to have a fever and chest pain that's worse with breathing, and when they're sitting back, they're going to feel fatigued. They're going to have tachycardia. You'll hear a friction rub when you listen. It's like like paper rubbing together. And you'll see some EKG changes, like a PR depression or ST elevation. The way that we treat this, that didn't want to work. Anyway, so we're going to treat with anti-inflammatories like NSAIDs, and if there is fluid buildup, we're going to do a pericardial centesis and drain the fluid off. The constrictive pericarditis, this is something that develops over time. The pericardium gets stiffer and harder. You'll see some non-specific ST and T wave abnormalities and even atrial fibrillation. But the pericardium gets really fibrous and scars up, so it constricts the heart that way. It's not necessarily a fluid buildup, but it's really stiffening of the pericardium, and it really affects cardiac output. So that fluid, like we were talking about, you can see in the picture here, we've got the pericardial effusion pushing in on the heart. It can be caused from the acute pericarditis that I just talked about, but it can also be from cancers or autoimmune disorders or trauma. The fluid doesn't necessarily mean that it's just the pericardial fluid that is in excess. It can be pus, it can be from infection, and then it can be from trauma. So you can have a very, like a car accident, patient's chest hits the steering wheel, and they end up with a little bit damage one of the arteries in the heart, and it starts bleeding into the pericardial sac. You can end up having a buildup of blood. So that could also be a type of pericardial effusion. So they'll do pericardiocentesis, they'll drain it, they'll analyze it to try and find out what it is. But like I had stated, it can be lethal. Once it gets 50 to 100 mLs, it can really squeeze down on the heart and completely obstruct any type of cardiac output. A clinical finding that you'll see sometimes with a patient that has a significant pericardial effusion is something called pulsus paradoxus. And what this is, it's the patient will have, when they breathe in, they'll have a significant reduction in their systolic pressure. So if you put a stethoscope to their chest and you listen to their heartbeat, and at the same time you put your fingers on their radial pulse, you have them take a deep breath in, and though you'll hear the heartbeat, you will not feel the pulse because the pressure drops so significantly. Talking about cardiomyopathy now, we have dilated, hypertrophic, and restrictive, and these can be either primary or secondary disorders, meaning that this could be the disorder that's going on. There's something wrong with the heart, and this is the primary problem, or this is a problem that's secondary to some other disease process going on in the body. With dilated cardiomyopathy, there's a strong genetic component, such as in muscular dystrophy. You have an increased cardiac volume and ventricular dilation, as you can see, that left ventricle is huge. But you do have a reduced ejection fraction. It's just a very dysfunctional, large, floppy left ventricle. With hypertrophic cardiomyopathy, you can actually have two different types of this. You can have hypertrophic obstructive, And this is a thickened septum. So you can actually see there, you've got the septum. Where's my arrow? There it is. The septum here is very thick here. And so when it actually squeezes together, if it's thicker up here and it squeezes together, the blood just can't get out. But then you also have hypertensive or valvular hypertrophic cardiomyopathy. These aren't the same thing, but they're the same function, where it's not necessarily, a thickened septum or dysfunction with the left ventricle itself, but over time it becomes dysfunctional because this person has significant hypertension. So like we talked about with the peripheral resistance, when you have high blood pressure, your left ventricle has to push out into that system that's under a lot of pressure. Additionally, if you have something wrong with your aortic valve, such as stenosis, you have to push against through this stiffened, hardened valve. So that pressure over time is going to cause hypertrophy of the left ventricle as it tries to compensate, that whole Starling's law, right? Where it will compensate with that pressure, but then it weakens the muscle over time and it becomes dysfunctional. So it's that resistance to the ventricular ejection. And then we have restrictive cardiomyopathy. And this is resistance to filling. So this is related to diseases such as sarcoidosis, lymphoma, scleroderma, amyloidosis. And there's restriction to filling because the myocardium is really stiff and rigid. So it's not big and floppy and dysfunctional in that way, but it's just really stiff and rigid, so you don't get that filling like you normally would in diastole, and then you don't have the volume or the flexibility, compliability when on systole. So let's talk about these valves. We've got our pulmonary valve, our tricuspid valve, mitral valve, and our aortic valve. And I put this picture up there so you guys can kind of remember where each of those are. Issues with the valves can either be congenital, born with them being defective, or they're acquired through some type of disease process. It can be inflammation, infection, trauma even. Ischemia is in a myocardial infarction near that site, and even degeneration over just over a lifetime. It's commonly caused by a rheumatic heart disease. So rheumatic fever is a big culprit when we talk about valve disorders. Rheumatic fever, it's a systemic inflammation which is caused by group A beta hemolytic strep. So kids get this strep infection. They end up having an exaggerated immune response to it. And if it's untreated, they end up with a heart disease, and that's called rheumatic heart disease. So the types of things that can go wrong with our valves. One is that they could become stenosed. Now you've got all of your different valves there and what they look like, what they should look like when they're healthy on the left, or on the top, sorry. And then what it looks like when they're stenosed on the bottom, where they're just not functioning correctly because of the stiffness. The aortic valve and the mitral valve are the most commonly affected when we're talking about stenosis. With the aortic valve, it can either be congenital. Instead of having 3 leaflets, the person is born with just 2 and it becomes a bicuspid valve. You can have degeneration with age, or like we were just talking about with rheumatic disease, it becomes inflamed and damaged secondary to that process. This does cause left ventricle hypertrophy, which increases coronary oxygen demand, and it can lead to dysrhythmias, MI, and heart failure. Now looking at the mitral valve, this is actually the most common valve affected in rheumatic heart disease. It leads to left atrium dilation and hypertrophy. So if you think about this, you've got your mitral valve, which is between your left atria and your left ventricle. So when we have issues with it, when your blood's not getting through it very well, it ends up putting pressure in that left atrium. And so that will end up hypertrophying, if that's a word. So they're at high risk. These patients are at high risk for atrial failure, dysrhythmias, and thrombosis. As it progresses, it can lead to high pulmonary pressures, edema, peripheral edema, and pulmonary edema, and right ventricular failure. As we know, this is a system, right? It's just a big circle, really, this whole circulatory system. So when something goes wrong in one part and it causes a backup and a backup and a backup, it's kind of like a traffic jam, right? You just have multi-car accident, so it just keeps going back and back and back. And so the worse it gets, the further back in the process it affects things. With these patients, you'll hear a diastolic murmur. Treatments include coagulation therapy, heart rate control, and even valve replacement. Now, when we're talking about regurgitation, we've got the stenosis that we were just talking about where things don't open properly. Regurgitation, we're going to talk about where things don't necessarily close properly. So during either systole or diastole, blood is going to leak back into the chamber it was just in prior to that phase. It increases the volume that is needed to be pumped. It increases the workload. And it leads to chamber dilation, chamber being either the atrial chamber or the ventricular chamber, whichever, is the one on the beginning side of it. It hypertrophies and eventually leads to cardiac dysfunction and failure. This is diagnosed by echocardiogram. They stage it as either at risk, progressive, asymptomatic severe, or symptomatic severe. Oh, I kind of went a little too fast there. So with the aortic valve, we know where our aortic valve is, right? That's the valve between the left ventricle and the arterial system. So when it's not working, blood's going to flow back. It's going to regurgitate back into the left ventricle during systole. So systole being when the ventricle contracts and tries to go out through the aortic valve, some of it's going to leak back because, the door didn't close all the way, right? So this ends up leading to left ventricle hypertrophy and eventually heart failure. In these cases, you'll see a widened pulse pressure. Remember, that's just the difference between the systolic and the diastolic pressures. And you can also see dysrhythmias. With the mitral valve, this is usually due to prolapse, which is actually pretty common. And it's just that the leaflet in the valve is a little bit floppy and it squishes back a little bit, folds back. So you end up with backflow into the left atria, leading to heart failure and pulmonary congestion. With the tricuspid, this is usually a congenital defect. Instead of being a tricuspid, it ends up being something like a bicuspid and it doesn't function well. But when it's seen in adults, it's usually caused by pulmonary hypertension. With mitral valve prolapse, it is one of the most common valvular disorders, and it's often asymptomatic. So this is kind of what it looks like, where you've got up here, this is your normal, these are the two leaflets of the valve, and here it just kind of, it's a little flexible, and it just bends back a little bit instead of staying down, and so you end up with this little bit of regurgitation in there. It's actually super common. I actually even have it, but I don't even know who caught it at one point somewhere in my life, but it doesn't make any difference. So many people have it, and it's generally asymptomatic issue. So moving on to heart failure, this is really the inability of the heart to generate enough oxygenated blood to perfuse all of our tissues appropriately. It can also be caused, though, by diastolic filling pressures of the left ventricle, causing pulmonary capillary pressures to increase. Risk factors here for the heart failure are ischemic heart disease, such as like MI, hypertension, age, obesity, diabetes, renal failure, heart disease like coronary artery disease, alcohol abuse, all of the things that are big players in all of our main morbidities. So talking about the left side of the heart failing, this is also called congestive heart failure. So you guys see that a lot. You see a lot of people diagnosed with CHF, and that's congestive heart failure. And you can have two different types, two different categories of this. And one is a reduced ejection fraction CHF, and a preserved ejection fraction CHF, which means one of them, the EF, is less than 40%, and the other one is actually a normal ejection fraction. What happens in these situations is that the oxygen demand of the cardiac tissue is just not being met. So the heart compensates over time, and this is called ventricular remodeling. So you'll end up with the hypertrophy, you'll end up with floppier, more flexible left ventricle, but this ends up decreasing the contractility of it. It increases the preload. So you have their left ventricle end diastolic volume. So at the end of diastole, that left ventricle just has a lot of fluid in it. It's this big floppy ventricle. So this causes the increase that we talk about with Starling's law, where we say, oh, the more you put in and the more you stretch that rubber band, the farther it's going to fly, right? You're going to have this great cardiac output. But like I said, that only works until a certain point, and then you get to a point where it just stretches it out and it's just not working. It's that old rubber band that just hopefully doesn't snap, right? But it's just not working. And that's your left ventricle failure. We have increased afterload. This is caused by hypertension or aortic stenosis, that the pressures that the left ventricle has to push against, and this leads to increased dilation of that left ventricle. We diagnose CHF by a lab value, the BNP, that natriuretic peptide, the B version of that is released into the serum. You'll see that circulating throughout the blood. And the higher it is, the more the damage there is. The chest x-ray will show cardiomyopathy, an enlarged heart, and then you'll see some EKG changes. The treatment is to decrease preload. So preload, that's volume. Remember we talked about preload really being volume and afterload really being the pressure that we're pushing against. Well, preload is volume. So if we give some diuretics and we decrease our volume, that's going to help. And then our afterload, so we give nitrates. So nitroglycerin helps dilate our arteries. It'll decrease that pressure, that systemic resistance that we have with the nitrates. And then we definitely want to oxygenate the patient, right? All of these patients, all these cardiac patients, we just oxygen, right? Inotropes to help increase contraction can be given. We want to be careful though and make sure that we're not going to increase the work of the heart. So we do give ACEs and beta blockers, angiotensin converting enzymes is what the ACEs are, to help decrease the work of the heart. And then we also want to tell them to have a low sodium diet. We don't want to be retaining sodium in water, and that's really for the long-term maintenance. And if you look at the guy in the picture, you can kind of see all of the different symptoms that they'll have. They wake up in the middle of the night with dyspnea, paroxysmal nocturnal dyspnea, that's just like out of nowhere in their sleep. They wake up and they just can't breathe. It's horrible. Orthopnea is that they have a hard time breathing when they lay down. Their fluids are really full of lungs, so they're drowning, so they need to sit up. You'll hear all of that. You'll hear crackles and wheezes. Sometimes they'll even have blood-tinged sputum. I mean, that's blood from their heart that has backed up into their lungs. And you'll have, cyanosis, fatigue, tachycardia, restlessness, all of the things listed there. And then we want to talk about right-sided heart failure. This is the inability to provide adequate blood to the pulmonary circulation, right? This is our pump for our pulmonary system. And this can result actually from left heart failure and myocardial infarction. So like I said, this is a system. So if you have left heart failure And that left heart failure, where is it going to back up into, right? So into the heart or into the lungs, and then the lungs into the heart, and then the heart or the right side of the heart into the peripheral vascular system. So it's just from, stepping back through the process and seeing as things get worse and worse and worse, a super bad left heart failure can cause a right heart failure because that blood backs up into the pulmonary system. Pulmonary system gets super congested. So now the afterload of the right ventricle pushing against the pressures in the pulmonary system end up causing a right ventricular failure. So it just kind of domino effects down the line. But most of the time, this is secondary to a chronic pulmonary problem. So COPD, cystic fibrosis, acute respiratory distress syndrome, COVID-19 would be a good example of what would cause right-sided heart failure. And so because these all just increase that right ventricular afterload. All right, so I'm going to stop this here and I will record part 3.